Good afternoon and welcome to everybody. Please be seated and join us at this sponsored symposium sponsored by Abbott on the role of MitraClip NTR and XTR, and is entitled More Options, More Possibilities. I'm just bringing to you what is this session going to bring you. What I think is important, we see lots and lots of patients with mitral regurgitation in the daily clinics. We see a lot of them with primary MR, and we see even more of them with heart failure and secondary MR. And a lot of times the medical treatment is not exactly bringing us, or bringing the patients, I should say, what we expect from it. So there is a lot of attention and a lot of hopes in the direction of MitraClip treatments. So what we're going to discuss is, first we will have a lecture by Francesco Maisano on the 15 years of expanding MitraClip experience. That tells us a little bit where have we been, where do we come from, and where are we going. Then we have information on MitraClip NTR and XTR in degenerative MR. And then we will look at the evidence in functional MR. And the functional MR is where the lesser certainty is, and what in my opinion is a very important target. We will then have a glimpse into the future of transcatheter mitral interventions, and we speak about what Mitra-FR is telling us. I think is a complex trial where a lot of different interpretations are possible. What I take from it, but you will hear from the experts, is that it's very important what patients we are treating. And with every disease, let's take, for example, secondary tricuspid regurgitation. If we come at the very end of a disease, probably whatever we try to repair is not going to work. So we need to probably move a little bit earlier in the disease to prevent these end-stage situations. That's my take on it. But we're going to listen to Professor Obadia telling us his details. Then we're going to look forward, together with Frank Ruzicka, on the impact of Coapt. That's going to be released in not long from now. So I'm also personally looking very forward. That's a different, slightly different population, and see what's going to come from that. So then we will speak about the TRIILUMINATE trial, if that brings us something new on MR treatment. Altogether, I would say, a lot of things being presented in a relatively short time, and I look very forward. So with that, I would like to introduce the very first speaker to us. He actually needs no introduction. Every one of you knows him and is actually a good friend. Francesco Maisano will speak about 15 years of friendship, or 15 years of expanding MitraClip. Okay, good luck.
Thank you, Jean. So, Jeroen is always really setting the stage for the discussions. And, you know, I've been given 20 minutes to talk about 15 years of expanding MitraClip experience, so I really wanted to enjoy this time together with you guys. And this is my personal development in the field. I started with Professor Alfieri. That's why I do MitraClip. You know, a lot of people say, why the surgeon is doing MitraClip? Well, I went through this evolution myself. I was doing Alfieri surgically, minimally invasively, and now percutaneously. I see this as an evolution. But this is really an evolution that took a lot of years to be reality. The first Alfieri stitch was in 1991, when Alfieri treated an anterior leaflet prolapse. The first MitraClip came in 2003, and it was again an anterior leaflet prolapse, the very first case. So this procedure was designed to treat degenerative MR to start with. And I remember when we started, Antonio Colombo is there. You know, you remember, Antonio, we had to take our own money from our pocket. We took 100,000 euros to buy ourselves the MitraClip, which was not reimbursed. At that time, we were negotiating with eValve, and they gave us 7 systems. So we treated the first 7 patients with our own private money. Probably Alfieri didn't tell you, but it was like this. And I remember the first data coming on at that time, 2008, 104 patients in the Everest registry. Everest is really the essence of this trial. Imagine how crazy was this startup. after a bunch of cases, to run a head-to-head comparison with standard practice surgery in the JDMR in an era when there was no 3D echo available. There was very limited experience of navigating in the left atrium. And so Everest was a challenge. But Everest remains an important trial. And I think it's kind of what we see now. MitraClip is always in the first line, the first trial against surgery, the first trial to try to demonstrate that 3D MR in functional MR makes a difference, always the first. What remains from the Everest trial is probably only that we have some data on long-term or mid-term. For a surgeon, 5 years is only mid-term, but mid-term outcomes, durability of these procedures. But I think an important step has been then having this guy, Seibel. And you don't know what is the connection between Seibel car and young Frankenstein, but basically is the scene when Frankenstein says it could work. And actually, I was totally against the concept of using MitraClip for functional MR. In surgery, was not working. So I said, no, it doesn't work. Until Seibel in 2007 sends me this video. And it says it could work. And actually, it works. And it was, for me, a revelation. For the first time, what you see here, directly online, you recognize an action on the mitral valve leaflets have an acute effect on MR. You actually see the MR going away with this procedure. Following this idea of treating FMR, actually came out the unmet need. Actually, DMR can be easily treated with surgery. Most of these patients are low-risk patients. So surgery was pretty acceptable. Functional MR was a problem also for surgery. So in the real world, and these are the data from the ACCESS trial, in the real world, basically 70%, if not 80% at the beginning of patients were treated with MitraClip were all patients with functional MR. And the registry was showing some signs of efficacy. Today remains this trend that functional MR is the most commonly treated procedure, problem with MitraClip. But also interestingly, there has been an evolution in practice so that in the latest data, these are the data from the pre-market evaluation of the new system NTR, XTR, that shows that 77% of patients do not match the requirement of the Everest criteria. So they go beyond what was considered the limit for indication. So there's been a tremendous expansion of anatomical indications in this field. What do we know about the procedure? Still not enough, but soon much more, and already today more than yesterday. There's been a lot of evidence which has been collected in different level of quality, I would say. I think this is the most important year for maturity of the device. Is time to deliver, right? This was the way that Frank Kruszczycka was messaging in 2018, because Coapt trial and Mitra-FR, and soon also the Reshape trial will be terminated and will give us a lot of information. So there are some differences between these functional MR trials, and I'm not going to go into the details because you will have a lot to discuss afterwards. And obviously, we all feel a bit beaten by this data that, for those who believe in the therapy, you feel beaten. And I think you can read this data in different ways, and I'm not going to talk about how much you can elaborate on the data, because again, Jean-Francois will do that, Frank will do afterwards, but we feel beaten. So round number one has been in favor of medical therapy. But in a boxing competition, there is also sometimes second round, and we hope that the results will be more sexy at the second round. So we'll wait a couple of weeks and we'll see what happens. But thanks God I'm not a trialist, and I will not bother you too much about trials. I talk about a little bit the technology. This is also important because if the trial become positive or negative, it's also because the technology is becoming better. We can treat better. We can achieve better results. And there is a pipeline of improvements. So we are now at the generation 3 in 2018 with new devices, which is, there is a XTR, which is a longer clip arm technology. But there will be larger clips, other concepts, better delivery systems, and obviously a version for the tricuspid coming in the next few months or semesters, let's say. You will hear from Paolo Denti more in detail and from Stefan how to use XTR in different pathologies. What is very simple here, it's a much larger clip, so it has expanded our opportunities of treating patients with more complex anatomies. The EXPAND study is a study which is collecting data on the experience. The main reason to run this registry is really to try to understand the indications and the strategy for choosing the size for specific patients. So we are collecting data, and sooner or later we will be able to have some more information. This is, I think, the very first XTR that I have done. It was a very complex anatomy. You can see it's a mixed disease. And this patient underwent a transeptal puncture, which has been done in a typical location, a little bit pretty superior, because now the new XTR, the NTR and XTR, they allow more trajectory, they're longer trajectory. And in this little video, I wanted to summarize the improvements. Number one, trajectory is improved, so it goes more straight than before, so there's more control, which means less risk of leaflet entanglement. The clip is larger, so also the visualization is much easier. It's pretty huge in some cases. Obviously, you need to be very selective in the indications. And obviously, the larger arms give you a lot of leaflet insertion, so we expect a lot of durability, but also efficacy with this device. Actually, this patient had a pretty good result, although he was a real complex post-endocarditis patient. So I don't know why he's coming back. Yeah. Now, when you improve your selection, your options, you also create a little bit of challenge. Now we need to learn how to choose between long and short, NTR, XTR. We don't know everything. Only what we know is that there is more efficiency, more leaflet insertion, probably easier grasping, probably reduced need for second clip, but at the same time, there is risk. There are risks associated. So we need to know which patients should be treated with a regular clip size and the larger clip size. We are learning that. I think we have been learning a lot in the first 250, 300 patients that we collected. We already generated some form of rules. But it is for sure that this is a much more powerful device which can improve your outcomes. But you know, if you drive a powerful car, you need to know how to drive it. And it's not like driving an SUV. Because this could be happening. Actually, this happened with the previous clip, perforations. What it is important here, we have seen today a live case demonstration. Clearly, now everybody is doing this. There is more force acting on the leaflets. You should dive while you close. It's very important not to pull on these leaflets. Now, the early experience overall with NTR and XTR shows that there has been a number of patients treated, more patients treated with XTR than NTR. This has been the very early phase. I think at the moment, most centers have inverted this trend, because still a lot of patients will benefit with the regular NTR. XTR is not a new device. It's just a new size. It's just like you have a Sapien or Portico 25, 27, 29, a Sapien 27, 20, I don't remember anymore, whatever. I'm making chaos. So you will see this slide several times during these days, which are the recommendations from the expert opinion. There is no study, no science behind. It's just the expert opinion. We have been trying to collect our knowledge. I think Stefan, Azim, and were part of this effort. Many other very active operators were involved in this collecting information. And so we have some initial strategy to share with you on how to select the size. It's about expanding indications, and there are some indications which are new, or let's say relatively new in this field. I have to say, last year I've done a number of these patients. You know, I have pretty much of an interest for hypertrophic cardiomyopathy, and I am fond of myocardial resections, and I do surgery, and it's beautiful surgery. But there are some patients really you can really benefit from a non-surgical approach. And you can see this case is a patient who has a hypertrophic cardiomyopathy where the main issue at this stage is a SAM. So she has under exercise a real important severe MR, and this is what you see in this particular case. During the exercise. So this patient I tried to treat initially with a regular NTR, which was ineffective for some reason, I don't know why. And after several attempts, I used the XTR. You can see the difference in this patient. I can go back 1 second. Look at the regular clip, how it looks here. Okay, this is a regular NTR, so the clip that you are also using every day. This is how it looks at echo, and now look at the XTR, much bigger, much more visible, and on top of that, super effective. In this particular case, we were able really to lock the anterior leaflet, so there is no more anterior motion, there is no gradient whatsoever, and no more MR. So it's a pretty good example of a new way of applying this concept. It's totally not new in surgery. For instance, we have done a lot of Alfieris in patients with hypertrophic cardiomyopathy in combination with resections. But in some patients, like in this case, where the hypertrophy is not dominant, this could be an alternative. I also wanted to share with you a case with NTR. Again, I want to emphasize that you can treat patients very well with the regular clip. The new clip is not going to be revolution. It's just expanding, okay? It's an expansion. And it's not that Barlow's disease needs always a larger clip arm. This is a patient with an end-stage so-called Barlow. So it's a Barlow disease which has been not treated for many years, and now there is also LV dysfunction. So there is a combined problem, and in this particular case, because of the size of the leaflets, because of the tethering, we decided to treat this patient with a regular clip, and I will go pretty fast on the procedure. It's a regular clip case with NTR with pretty good procedural outcome and 1 month follow-up with no residual MR. So again, it's a matter of doing the procedure well, independent from the size. Tricuspid is coming as well. You know, this is a off-label application of the technology. I don't even know if I am allowed to show it in a sponsored event, but it is standard practice. There are patients with tricuspid regurgitation who can get some treatment with MitraClip. This is a patient with mitral and tricuspid regurgitation, both of them relative to a Barlow's, a severe mitral and tricuspid insufficiency. The patient got 2 clips on the mitral, 2 clips on the tricuspid, and I wanted to show you just because I love the fluoro picture. At the end of it, you see 4 XTR altogether. This is the result. Almost no TR. And this is the picture at the end with 4 XTR implanted in the same patient, 2 on the mitral and 2 on the tricuspid. Okay, we have some. Okay, the computer is blocked, so that's why probably was. And it's not a big deal. We can. You want to go for? Yeah, it's blocked. Yeah, okay. It's okay. It's gone. It's dead. It's fine.
Now we put your presentation on an invited.
It's
on another computer.
Okay. So how do I go forward then with this? It doesn't go forward. And again, this is the result, 1 month, no residual TR, no residual MR. Now, obviously, these are at the moment off-label because there is no indication specifically for tricuspid implantation, but Abbott is working on a tricuspid version of the MitraClip, which the name I think is TriClip. I don't know exactly if there is a name. I think now there is a trial, which is a TRIILUMINATE trial, which is a pivotal trial, which is aiming at defining the indication for this procedure. And don't forget that the expansion of indication, expansion of opportunities includes also mitral valve replacement, which I think in many patients would be a good alternative with excellent results. Tendyne is really associated with probably the best results to date in this field. I think we should have always the mind open to different approaches, different solutions, targeting different problems and specific patient problems. Thank you for your attention.
Thank you very much, Francesco, for this elegant lecture, which sets the stage very clearly. And then I would like to ask the second speaker, Dr. Paolo Denti, to speak about MitraClip NTR and XTR in degenerative mitral regurg first. Please.
Thank you for the kind presentation. Dear panelists, dear audience, I'm really delighted to have the possibility to talk about the strategy of how to use this expanding new field device. When I was learning from Professor Alfieri and Professor Maisano how to perform the perfect edge-to-edge procedure, they said to me that I had to respect the symmetry and that the suture length should be kept to the minimum effective to correct MR. This means that I had to use larger bites and longer suture in order to achieve the best result for stability at the beginning and also long term. We have now published a good result of 90% of freedom from reoperation on the edge-to-edge in degenerative patient at 24 years. But we were using longer suture with longer bites of the sutures. Finally, we have this new device, which is the MitraClip XTR. The R feature gives, as Francesco said, more stability to the trajectory. So you are more precise, you are more surgically oriented, so you are able to implant the clip, and it's more simple to implant where you want because the trajectory is more stable. With the X feature, you have a bigger suture, longer bites, so you can include more tissue inside of the MitraClip, so you can be more radical about the treatment, especially in degenerative mitral regurgitation. As we know from the Everest trial, once you have a stable result in the first 6 months, you have this result that will be stable for 5 years. So if we are reaching more stable result from the beginning, we would expect to have a more stable result at the long term. I show you some examples of how to use the new XTR. So a simple case, I'm always talking about high-risk inoperable patient. So this patient was deemed inoperable because of the high creatinine, and we didn't want to put the patient in dialysis afterwards. We have a tiny flail of the posterior leaflet. As we can see here in the explain, there is a posterior flail of the leaflet. It's a tiny, it's less than 5 millimeters. And it was maybe one of our first patient treated with this type of therapy. As we can see here, the puncture. The puncture is very important. Since the trajectory is more stable, we have to not to pay more attention, and we have to pay attention as usual, but we have to know that if we made the wrong transeptal puncture, we can be more difficult to the procedure. So we have to pay a little more attention. We don't have to go to more superior because we can have some of aorta hugging. As we can see here, we have the trajectory on the left side that is really stable. It's not moving the clip also if it's touching the leaflet. This is the orientation. If you open the clip completely, you see it better for the orientation. And then you have the grasping. You can see here how the leaflet goes onto the arms of the clip, and then you can close the gripper that has 2 rows of more gripper. This means more strength implantation of the clip on the leaflet. So we close the clip, we evaluate leaflet insertion, and then we evaluate efficacy. As we can see here, no or mild MR after the closing completely of the clip. No gradient, free. So we decided to release the clip. This was the final result. So as you can see here, there is no more prolapse. We also increased the pressure with an alpha agonist in order to be sure that there was no prolapsing segment residual. And as you can see here, there is no more prolapse with a nice result in terms of reduction of mitral regurgitation. There was the flail there, and there is no more flail or prolapse in the right side image. After 6 days, the patient was home discharged. So the new clip, as I told you, this is a little bit technical, but only to you to understand that you have to pay a little bit more extra attention about the puncture. You don't want to be aorta hugging, so don't go too much superior, and you always have to be posterior or mid-posterior on the short axis. The trajectory is most stable, but the clip doesn't forgive you, so doesn't self-adjusting. This is what was happening with the old clip. When you go up with the clip was a little bit going a little bit anteriorly, so you were more able to grasp the anterior leaflet. Now, if you have the trajectory that is completely wrong, the trajectory remains completely wrong because the trajectory is more stable. So you have to pay a little bit more attention of the grasping of the anterior leaflet because the clip doesn't deflect. And second, as you can see here, the trajectory. In the first trajectory, you are a bit aorta hugging, and so you are not able to grasp completely the anterior. If you correct the trajectory, you are more coaxial. This is the same patient. We only change trajectory. You are more able to use the clip in this patient. Then you have to pay a little bit more attention about the rotation. You don't want to rotate the clip inside the ventricle, especially if you put a lot of M knob, because the clip starts to rotate and the clip is bigger, so you don't want to entrap. And as Francesco said, you have to release tension during closure. This is what's usually happens with a standard clip. You go up and you close the clip. Clearly, the arms, the final part of the clip arms goes beyond the annular segment. So when you close the new clip, since the arms are longer, you have to release a little bit the tension. This is at least what I intuitively have done with the standard clip, but I pay more attention to do it now when I'm using the new XTR. So, as Francesco said, there was a consensus. We start prevention. I usually start with the DMR patient with XTR, but I try to avoid XTR in small valve area, commissural jet, and fragile patient with fibroelastic deficiency because somehow you have more stresses on sutures. This is another patient that we treated, iris for surgery, but you can see here how wide was the prolapsing segment. This patient was deemed inoperable because of a FEV1 of 30%. So we implanted this patient with 3 XTR clip, and they say with a pretty good result. As you can see here, it was difficult to grasp the leaflet. It was not difficult to grasp the leaflet, but the clip is moving a lot. And every time we release before releasing every clip, we looked for the gradient, and we never had a gradient that was more than 5. For this reason, we implanted the first clip centrally, the second one lateral to the first one, and since the gradient was suitable, there was a tiny jet medial, we decided to put a third clip in the medial part. As you can see here, the rotation is looking to the smile of the mitral. So despite there was a huge prolapse of the posterior leaflet, we completely abolished the prolapse of the posterior leaflet. We have a gradient mean of 4 with 3 XTR clip. The patient after 4 days was home discharged. Again, another patient with A2 prolapse. So at the beginning, there was a little bit of discussion. We know that anterior leaflet is more fragile or it could be a problem. So let's start with XTR or NTR. We decided to start with the XTR clip because it seems that the patient could benefit from this type of procedure. So this is the prolapse of the anterior leaflet, prolapse and flail. This is the clip. This was not the final orientation. The final orientation was more AP. This is a little bit clockwise. So we implanted the first clip, and after releasing, we evaluate the grasping. There was a good grasping and mild residual regurgitation. But when we release the clip, there is a little bit of prolapse again of the anterior leaflet, so we decided to put another clip. For the second clip, we always decide to discuss, but at the beginning of our experience, we always start using XTR. In this case, I think it was a good strategy. In fact, no more prolapse of the anterior leaflet, no gradient, 2 of mean gradient. As you can see here, the different length of the two clips, the XTR and the NTR. After 4 days, again, home discharge. We are talking about high-risk patient with the degenerative MR with good ejection fraction. Another patient that had a prolapse of the commissural jet. This commissure, I would start with the NTR because we said that it could possible, but since the prolapse is not in the real commissure, but it's a little bit on P1 near P2M1, so we decided to start with the XTR, which was the jet, clearly P1 prolapse. So we started with orientation that is clockwise. We implanted and we were looking to the flail. This was the result. That was quite good, but again, there is a little bit of prolapse of P1. So to be radical, in order to be sure that we have a good result and a stable result, we decided to implant a second clip. Which clip to implant, XTR or NTR? Since we were very shy and at the beginning of our experience, we decided to use an NTR, more stable but with less length, and we know that we are in the commissure and it could be possible to entangle into the leaflet. So at the end we implanted the second clip. We have a wonderful result, let's say really good result with mild regurgitation. So sorry, it doesn't work. And no prolapse of the posterior leaflet anymore. So it's the final message? The R feature gives us more precision, surgical precision. The X feature gives us a more radical result. This, in theory, can give us more stable and more durable result. This is my last slide. Thank you.
Thank you, Paolo. We will move forward to the other side of the disease, the functional MR with Stefan von Bardeleben, and then we will discuss all together a little bit if there is time left. Hopefully, Stefan, your slides will work.
I hope we can advance it. Get a sand clock here. Can we finish the presentation, previous presentation?
Yeah.
Okay, this looks good. You will start it for me. Thanks a lot. So I will now draw your attention from the degenerative disease to the functional mitral regurgitation, which has come under some discussion with the upcoming New England Journal paper of Mitra-FR and Coapt. These are my disclosures. So when we discuss the second half of the mitral valve disease, we have to differentiate 3 different disorders. One is LV dysfunction, either caused by non-ischemic disease or ischemic dilated cardiomyopathy, which you will see in the samples. But there was also a very nice publication in Lancet this year with an analysis of the Mayo Clinic, Olmsted County, that showed that approximately 20 to 27% of the patients actually have an atrial involvement. And this is especially true in the patient population above 75 years of age. So atrial dilatation leading to annulus dilatation is another disease entity that will enter the guidelines in the upcoming years. The mitral valve repair situation in Germany, as you can see here, has increased quite a bit, but there are, of course, caveats, as you see at the bottom. There's a treatment range of 64% FMR treatment, but we, of course, have the neutral results of the Mitra-FR trial just published 2 weeks ago at ESC in the New England Journal. But there's also an upcoming presentation in 2 weeks' time, exactly 13 days, of the Coapt trial. And as David Adams put it already at the Mitral Valve Summit in Zurich back in February this year, if Coapt may be positive, the Germans will say, "I told you so." So we now look into the different treatment options for this disease. And as you have already seen, we have a change in the coaptation length that is leading to a coaptation length of 12 instead of maximum 9 millimeters with the classic NT or NTR system that is basically unchanged in its size but has a different trajectory to move into the left ventricle. The system, as you have seen in the first talk, is the third generation of the MitraClip adoption. It is intended to achieve further MR deduction. It also should expand the range of mitral valve anatomies that are treatable with the MitraClip system family now, and it increases steering precision and ease of use. We've already seen this slide, but I just want to highlight 2 different points. The etiology is still in the pre-market analysis, approximately 56% pure functional disease, which is the majority, but you also see that the rate of DMR or the rate of mixed disease is increasing to up to 44%. The complexity rather is high, and as you can see, only 23% actually follow the original Everest criteria. On the right-hand side, for both groups in functional disease as well as mixed disease, you can see that there is a predominance of XTR use in the early market experience in 150 procedures in 24 European sites. There is an upcoming EXPAND study with 1,000 patient inclusions where we'll learn more about the selection of patients for the 2 different devices. But you can also see that the NTR prevalence is much higher than in the degenerative group given by Paolo Denti in the previous talk. So I want to start with 2 different aspects of the treatment with the XTR system. And as you can see nicely on the right-hand side, you see the tension in this patient with a circumflex artery infarction on the cords leading to the posterior medial papillary muscle. And it's very nice to see how much tension we actively induce to those existing cords that lead into the area near the aneurysm as well as on the leaflets themselves. So the maximum shortening that is now achievable, which goes beyond 9 millimeters but reaches 12 to 14 millimeters, of course also has an effect with the huge arm length of 12 millimeter and the caudal tensioning. This can also be seen with the different tensioning aspects here in different areas of functional disease, as shown in this example in one and the same patient. And again, if you look into the lower images, you see that we actively pull at the aneurysms and we use caudal structures to do so. So this is pretty similar as caudal sparing in replacement techniques. You still see that the XTR or NTR can produce fantastic results if the size is suitable, and this gives you the result in this patient with a circumflex infarction with no residual MR in a single clip involvement. So I'll come to the first FMR case where we had to decide just to use actually in this huge valve an XTR and FMR. You can see that it's a severe regurgitation that goes all along the P2 segment, and you can also appreciate that the size of the annulus in this case exceeds 45 millimeters. So this is an ideal patient actually for the larger XTR system. Again, note, like in the degenerative disease patients, how large this clips in an open arm span of approximately 25 millimeter appears compared to the mitral valve. It is easy to grasp, as you can see on the right-hand side, so this is no rocket science anymore. And if you close the clip, as you can see here, you put the grippers down, you close the clip. This is approximately a 6-7 minute procedure. And if it's done in the right space, you get no residual MR whatsoever. So perfect result with one single XTR clip. But the world is not as easy as this. And now I give you a case demonstration of two different sizes in the same patient. Again, you see it's a functional MR. We have a dilatation of the annulus, but you see the inversion actually of the hinge points into the middle of the valve. And now please recognize the size of this XTR clip on the right-hand side. It seems even to extend above the annular shape in the AP diameter. So it's a severe regurgitation once again. You can see that we nicely address the middle of the regurgitation jet with a single XTR clip. This is the closure of this device, which goes near to the hinge point and the muscle, actually, of the posterior ring. And if you see the result, it is far from being perfect. Just removing this XTR clip and changing to an NTR clip, as you see in this movie here, actually changed the whole picture. The clip now appears to be much smaller in relation to the ring. Again, we're able to grasp just the leaflet only with 9 millimeters extension into the clip system. You see the result with a single NTR clip, and the result looks far better in this case with tenting leaflets. What you can also see in this image nicely is that the clip has a far higher degree of annular shape differentiation than ever before. Just look at the left lower image and just look for the annulus shape and the annulus size compared to the clip. You see that we have a typical round shape in this functional disease patient. After clipping this patient, this annulus becomes totally elliptic, and the regurgitation in this patient is totally gone in a compliant ring. So my take-home messages for mitral XTR and NTR in FMR interventions is that XTR and NTR offer two different leaflet insertion length options for FMR treatment. XTR needs a compliant posterior mitral ring structure and enough tissue reserve like in DMR. It's easy to grasp, but coaptation length is pushed to a maximum of 12 millimeter, which exceeds the current systems. So it's ideal for large non-calcified annulus in A2, P2, both in DMR and FMR. NTR, on the other side, is identical in treatment options to the old NT system in FMR. It has less AP shortening, less leaflet stress, only 9 millimeter coaptation length. It's better suited option for small annulus, nodular calcification, better suited for FMR with chordal and leaflet restriction. Both new MitraClip options in the PME trial seem to be safe, but XTR has to be used with some caution to avoid leaflet damage. If in doubt, use the NTR system. Thank you very much for your kind attention.
Okay, so we are open to questions. If anybody would like to ask questions, I assume there are a lot of different things. We are now focusing on the technical part. We will discuss the clinical issues and the trials in the second half of the session. While somebody thinks about a good question, I ask a question to Stefan. You showed us this new imaging technology, which is basically changing the way you make the shadows. Besides being beautiful, what is adding to to your procedure? So it's a new software. I think Philips is doing this, right?
Right. It's one of many software rendering options. Actually, it's a commercial software tool that can be applied to any RF signals, to any ultrasound. So it's actually not totally proprietary. It comes from Pixar Studios, so from Hollywood. And what they're doing is that we have a rendering of the surface that appears like a natural surface in the heart. What it does, it changes the wavelength deterioration of red light, green light, and the different spectral situation, and it can also detect the thickness of tissue in the echo images. So there are many different use models. You can use it with a higher spatial resolution to detect the residual opening of the mitral valve or the initial opening. You can detect different thicknesses of the mitral leaflets, and you can also easily detect paravalvular leaks, just for some examples.
Okay, so, but I think it's very interesting, you know, is this technology solving the problem of shadowing or not?
It will in the future. What we get is a better smoothing. You saw that in the middle, still the metal shadow was persistent. But what we can do is we can test a natural shadow from an artificial light source to devices. So what we can do is we simply have an LED bulb in the heart, and we can change its position. So we get an additional shadow where we can differentiate a shadow caused by a device or by calcium versus shadow by devices or structures in the heart. So it's easier to see cords, it's easier to see masses, it's easier to see leaflets.
And just a little question, obviously, you are a super expert of both procedures and imaging, so you are one of those hybrids who are doing both things. I know what that means to be hybrid. Sometimes it's difficult. Do you think this new technology is going to help or going to create more confusion in the real world?
I think we're...
Maybe you can see things that you know...
Don't want to see.
Exactly.
Well, the situation, the human eye is not able to differentiate a lot of gray shade differentiation. So normally we're only able to differentiate approximately a maximum of 60 different gray shades. So the machines offer you 256 or 1,000 nowadays. If you add color to this, you get a better perception of 3 dimensions, and you get also a better situation that you can differentiate different thicknesses and intensities with color added.
So thank you very much. Just before we continue, I have a short question exactly to Francesco. So could you share with us at this moment in time which patient we should not treat, because that is probably also quite an equally important topic as the ones we should treat. Which one do you advise us that we at this moment in time should not treat?
So I will answer you, first of all, only on the anatomical basis. I will not talk about the clinical indication, which is, I think we should answer this question after hearing from the trials. From an anatomical perspective, I think we should be very careful treating patients with leaflets which are thickened, which are less mobile, because these patients may develop degrees of stenosis. So the typical example is rheumatic mitral insufficiency can be a problem in these patients. Probably this new imaging that gives you some thickness feeling could be helpful. Another area where you should be careful is fragile patients, elderly patients with DMR and calcific annulus. These are patients where you have a little bit higher risk of leaflet perforation. Is an underestimated problem, but we have seen some of these patients. So before thinking that this is a low-risk procedure, if you have a perforation, it becomes a super high-risk procedure, because the only solution usually is surgery. Sometimes you can fix with Amplatzer. So out of these 2 anatomical contraindications, I think really today there are no other anatomical contraindications for mitral. So forget about the Everest criteria, because they may predict efficacy but not feasibility. You can improve MR in almost every patient today with this device. So technically we can do everything. Now I think we should move to the second half of it, which is to define the indications in that field where we work in a gray zone. So if there are, how many 60 degrees of shades of gray?
We have 250 in the ultrasound systems.
I think
we're not able to see them all.
Yeah, I think in functional MR really there are even more than that, and I think it's the best way is to start with the shocking news from Jean-François. So Jean-François Obadia, for those who don't know him well, because you are not French, is a good friend of mine, first of all, since many years. We share a passion for mitral valve repair, and also we share the same passion for being open to alternatives, because he has been the PI of the Mitra-FR, which is the first randomized trial comparing MitraClip to medical therapy in heart failure. Tell us about your outcomes.
Well, thank you, Francesco. It's my pleasure to answer to your question. These are my conflicts. Well, I don't think it's really necessary to go back to the physiopathology of the disease, but let me remind you, my dear Francesco, the time when you and I did a surgical repair If I refer to your first slide, you see when you have the evolution of your career, the left side, when you and I were baboons. You remember this period? In this period, we tried to convince the cardiologist that we had to operate some functional MR, and we had the feeling that in some patients we were helpful. But to be honest, the result we had were rather disappointing, and one of the first surgeons was Steve Bowling, who presented his result. And as you see, when propensity match analysis, there was already no difference between surgical patient and medical treatment. So, as surgeon, we missed arguments to convince the cardiologist. And there is also this prospective randomized papers, and there are not so many, and this one is important. But unfortunately, in these papers, there is no medical treated group, no control group. But if you compare repair and replacement, you see absolutely no difference. And what is very important here, if you see here, we had at 1 year more than 30% of recurrence of functional MR, and at 2 years this recurrence was almost 50% of the patients. So in this condition it was difficult to convince the cardiologist, but after decades of fine-tuning, the surgeon have been able to develop some indication when the surgery could have good result. And here, as our conclusion, the angle between the posterior leaflet and the annulus, the importance of the tethering, the left ventricular function, there are many elements who can predict the quality of a surgical valve repair in these instances. But in the meantime, the percutaneous technique appears, and there is no possibility to defend surgery against the percutaneous technique, which in the hand of Stefan can be done in 6 minutes. We have learned that a few minutes ago. Thank you, Stefan. Congratulations. But so we had to compare. And this is our study. We had one arm with medical treatment and the other arm with the MitraClip in addition to the medical treatment. And our primary endpoint was composite death plus unplanned hospitalization for heart failure. Our inclusion criteria was the patient who was symptomatic, at least one hospitalization during the last 12 months. The surface of regurgitation was above 20 millimeters square. This is important because this is according to the European guideline, which is different from the US guideline, which is 40 millimeters square. And also, as you see here, the ejection fraction was really low, down to 15%. Of course, the heart team has to confirm the indication, and we had a centralized core lab who assessed all echography before the randomization. And after this acute selection, we randomized 300 patients, 152 in each group as an intention to treat. We also had a second evaluation in a per protocol analysis comparing 109 patients who really received the clip versus 137 patients who didn't, and respecting exactly the protocol. And these are the baseline characteristics which confirm the quality of the randomization. No difference between the groups. 2/3 of the patients were in class 3 or 4, meaning it was a very sick population of secondary MR. 60% of ischemic cardiomyopathy. The mean ejection fraction was 33%, and the surface of regurgitation 31 millimeters square. Importantly, you see the BNP level was very high, addition confirmation of the severity of our population, and the medical treatment was particularly accurate. As you can see, almost every patient received diuretics. More than 90% receive beta blocker, more than 70% ACE inhibitors, and so on. And as you can see, the systolic pressure was very low, which is a confirmation of the up-titration and the quality of the medical treatment we receive those patients. Concerning the results, the safety is is confirmed. No death, no conversion to surgery. We had 3.4 vascular complications, few stroke and tamponade. And concerning the efficacy, we confirm what has already been published in the literature. That is to say, 94% of the patients who had a clip in the best condition with regurgitation grade 2 or less. And if you compare to all the different publications in the literature, you see that we have now a success rate which is comparable to all the registry reported today and much better than the first publication with Everest 2. So we are at the level of the best report today. We have also confirmed that the control of the regurgitation was efficient at discharge, and while it is not perfect, but you see that after 12 months, we still have 83% of the patients who are still in grade 2 or less of regurgitation, and in addition to that, the patient did better. You see an improvement, less patient in grade 3 or 4, and the difference is significant after 12 months, but this is, you will see now what it is so important to have a control group, and this is why we need prospective randomized study. And you see that if you follow very well your patient with a medical treatment, you see that the medical treatment is also efficient to improve, and as a consequence, there was no difference between the two groups. And this is what you see on this slide. Our primary endpoint was neutral, no difference between the patient who received the medical treatment alone and the patient who had a MitraClip in addition to the medical treatment. If we split our composite endpoint, no difference. You see the mortality rate, which is very high, 24% almost in each group. Rehospitalization rate close to 50%, so it was a very severe population. If you do the per protocol analysis, that is to say, comparing the patient who really received the clip versus those who didn't, no more difference, so the results are really neutral. And we have also tried to do subgroup analysis, and no difference in terms of ejection fraction, no difference in terms of severity of the clip. And as a consequence, our conclusion is that the addition of a clip in a severe population can be safe. We have confirmed what is published. We really decreased the regurgitation, but we didn't change the prognosis. But it is important to notice that if our conclusion is very strong on the statistical standpoint, if we had included 1,000 patients, the conclusion wouldn't be different. We were perfectly sized, no underpowered evaluation. The MitraClip doesn't work in this specific population of severe patients, but this doesn't anticipate the result of Coapt, because Coapt addresses a different kind of population, and I think it will be very interesting to compare the two studies. And I remember to the cardiologists that in the very phase of the treatment of this disease, as surgeon, we try to convince the cardiologists that we had to operate on the patient at an earlier phase of the disease, and maybe this is what we can have as a conclusion after Coapt. It will be very interesting to get those results. Thank you for your attention.
Thank you very much. Thank you very much for the excellent presentation, sharing with us your results. And then I would like to ask the next speaker, which is a good friend also, it's Frank Ruzicka, who's going to talk to us about anticipating the impact of Coapt on MR management. Before he starts, I'd like to ask each of you to fill out the paper for the company to grade what we are sharing with you. Frank, please.
Thanks, Jerome. Thanks, Francesco, for having me. This is probably the best fun we ever had in Mitral, the most exciting. Some of these years, the last 5-6 years when I gave talks at EuroPCR, people looked at me as I was an alien when I told them, guys, it's an exciting therapy, happy to embrace it, but don't be naive. It's not good for everybody. It will be good for some, and let's work together to define the patient who will benefit. I published that many times, and see what the promise, whether we will deliver on that. That's, first of all, these days you have to declare your interest. I have a lot of interest, but all my money, what I get for even talks like that, goes directly to the university. One thing, I'm an impatient guy. Everyone here in the room is. We are alpha guys, we're cardiologists. I can't wait. But why did we have to wait that long? 6 years, 7 years. Well, trials take time, but we've been talking with the industry in 2008 and 2007. Some of the trials, we should have had more. And that's why I have the greatest admiration for Jean-François, how he pulled that through with this independent source, that's very important, and came up with data. And anyone who wants to criticize a trial of that size, first of all, he delivered. He should publish a trial the similar size in the same circumstances as well. And so to put it in perspective, where we are, with any innovation, we have the hyperbole. In the beginning, we get excited, we get greedy, we get impatient, and we have a peak of expectation. They're a little bit inflated. And it's so seemingly suitable, it's like the Everest of expectations. This is where we were with Everest 2, although it didn't really give us much of a signal in FMR, although the Germans thought, right, that's already there, and I told you so. So everyone went on implanting an FMR. Then came Mitra. It's a trough of disillusionment, and luckily, we're going to have the new trial coming, whether we will be in depression for too long or not. And these trials that are around the corner in 2 weeks is Coapt. And the other one is very important, that's round 3, is Reshape HF2. We're going to talk about that in a second. The one thing I want to make, the point I want to make about Mitra-FR, it's a wonderfully done trial. Patients were very well treated, one of the best heart failure treated patients I've seen in a trial. Look at the beta blocker, ACE inhibitors, whatever they got, really well treated. That explains you a lot already. But whatever it is, and that's the impatient guy in me, these patients, after 1 year, 50% have an event. They are dead or back in hospital. That shows us the unmet clinical need. That doesn't mean that we should do anything in there without evidence, but it tells us there is an imperative that we have to work harder and get a therapy delivered. Unfortunately, the trial was as neutral as the day was long. In trials, you have to look at consistency of data. So there is a very substantially important message here, whether it's that trial population, the very advanced disease, but there was no glimpse of hope whatsoever. And keep that in mind. And even the symptoms were not delivered after a year, not getting better because, and we are, Francesco and I just discussed it here right now, and at home we do all the time. Well, it's interestingly that after a year, the medical treatment was, the patients were still getting better and better. Keep that in mind. In medicine, and that's my take on Mitra though, is one trial will not explain it all. In medicine, in life, in anything you do, there's no such thing as an unmitigated good. This is Eugen Bleuler. Actually, Francesco and I, he would be neighbors if we're still alive. He is from Küsnacht, like Francesco and I. It's a little village next to Zurich. He coined the term schizophrenia, which he called dementia praecox. And he said, when he wrote to Sigmund Freud, who at that time thought he knew everything, he said, this all or nothing, in my opinion, is good for political parties or religious communities, but for science, I consider it harmful. Well, keep that thought for all what we have been discussing. Coapt and Mitra-FR are synergistic, they're complementary, they're not round 1 against 2 knocking out. Even Reshape, it's part of the mosaic. We want to understand, because in heart failure, we do not understand the enemy. It's not a monogenetic disease. It's actually hundreds of diseases. If you go into the heart failure world, that is not one disease. There are hundreds. So you need a lot of trials to provide you answers. So this is the clinical course of heart failure as we know it. I think what we learned from Mitral-FR, that there is a no-go zone if it's too fast. But the problem is, oops, no, I have a problem with mine as well. Nope. But we can do something. There's a lot of drugs we can throw at them, ACE inhibitor, beta blockers, MRAs, ARNIs, but ICD, CAT, VADs, transfer. We have 8 life-saving therapies in heart failure. And that's important. But the key thing is that we have to find the sweet spot of response. And when we talk about Coapt in the future and Mitra-FR and putting in perspective, take some lesson from cardiac resynchronization therapy, CRT. There, we have a lifesaver. With CARE-HF, we saved lives with patients with dysynchrony and left bundle. But in Echo CRT, Jerome, we did it together. In QRS below 130, there was no benefit. There was actually harm. The sweet spot for response is actually 20 to 30 milliseconds. Look for the sweet spot in our patients with FMR. This is our task. And this is how we write our guidelines. In below 130, it's a no-go. It's above 150, a 1A. So Coapt will help us really get a deep dive into the data and get us a better idea of what we are doing with MitraClip. It's big-sized. It's adequately powered. They increased their power by 180 patients recently to 80 sites in the US, 300 roughly. And the trial, when you look at them, I just highlighted Mitra and Coapt here. The one big difference is recurrent hospitalizations. That's also something we look at, and one of the PIs of Reshape, Stefan Anker, is in the room, also at Reshape. It's adequately powered, I think, Coapt, and has a different time of intervention. I think you are seeing more advanced patients in Mitra. That's why I think it's more likely to win Coapt than Mitra-FR. But hold your thought. This guy is one of the PIs. You know him all. He's already smiling. You can't. He's a New Yorker. You can't wipe the grin out of his face. And the 2 years roll-in results of Coapt, that's what they had before, actually showed very promising results. In the interest of time, I cut that short. A substantial hospitalization for heart failure reduction. Well, we'll see how that pin out in the big trial then. The big ifs are coming to an end with a crystal ball we're looking in 2 weeks. What's going to happen if Coapt is neutral? That's not the end of the world, but we have to look at subgroups. But they are then, when the primary is neutral, hypothesis generating at best. Then we have to understand it's heart failure. It's a ventricular disease, not only a valve. But they beget each other. See them as a combo. If Coapt is positive, will there be a primary? Of course, otherwise it will be positive, recurrent hospitalization reduction, but will there be an impact on survival? Will that ask ourselves, was Mitra-FR too small? I don't think so. They delivered on that population they tested. There was no glimpse of hope at all. What Coapt, if it is positive, a big ifs here, but we have to rethink the way we select the patients, whether we should not go too advanced, and whether the timing of the intervention is not the key question. And we have to find the sweet spot. That's how I see it. I think we should go here, between the first and not the second or third, not certainly in this no-go zone of advanced heart failure. But where that's exactly going to be, well, let's wait for the papers, and then we can decide. This is how I see it. The hype cycle of FMR. Mitra is where we are at the moment. There's some hope inside. We keep our fingers crossed for Coapt, but I can't stop telling you that we also need more. We need many more. We need different devices from reduced FMR, and we importantly also have to beef up Reshape HF2, otherwise we are not going to have an answer for that. Think CRT. No such thing in life is free, but no such thing in life is there that works for everybody. And I think that's my take on Mitra-FR and Coapt. Thank you so much.
So, thank you, Frank. It was an excellent second round. Before we go to the final match, I think we would like to hear from Azim also another perspective, which is the TRIILUMINATE trial, which is addressing the very end stage side of the story, which is tricuspid insufficiency. And Azim is going to tell about what if we can learn something from this trial as well on MR?
Great. Thank you, Francesco. So it's the last talk of the session, and they always put tricuspid at the end, but it's an opportunity as well to discuss with you a little bit, give you some background on the prevalence of tricuspid regurgitation, the prognosis, particularly when there's left-sided disease. I'd also like to share with you some of the data that's available on tricuspid clip from real-world data, as well as this important study, early feasibility study, TRIILUMINATE, which will be important for the CE mark of this therapy. These are my conflicts of interest. So the prevalence of TR, I think the picture on the left most of you have seen or will see in these next few days. It's a picture often used. These are quite old data from the US showing that the prevalence of TR is about 1.6 million, and there are about 250,000 new cases and only 8,000 patients who get operated on, so less than 0.5% of cases. There are some newer data. On the right, you see data from the UK, particularly from Oxford, in a more community-based setting, looking at over 4,000 patients who are older than 65 years of age. And if you look at the prevalence of tricuspid regurgitation, it's 2.6% higher than aortic stenosis in this study. We also have data from the Mayo Clinic and from Olmsted County, and looking at, again, a community-based study, 417 residents who had great or equal to moderate TR. And in this community study, TR, the prevalence was 0.55%. It accounted for 1/4 of all left-sided valvular heart disease. And if we look at the mechanisms, majority of patients, this is obviously functional TR in the majority, and you see majority of patients had left-sided valvular heart disease as the cause of the TR, followed by pulmonary hypertension, LV dysfunction, and isolated TR was actually 8.1%. What's interesting in this community study in the Mayo, that only 2.6% of patients ever had tricuspid valve surgery. So even in that community where patients were fairly well followed up, there's really this discrepancy between the number of patients and the fact that they're being treated. Well, should they be treated? What is the prognosis of TR? Well, we have a number of studies showing us that it has an impact on long-term survival. And the study on the left is the study from NETH, which most of you know, and is probably the most quoted study, showing that severe, moderate, as well as mild TR have an impact on mortality. However, it's a little bit small, and I hope you can see it. If you look at the patients, they are very different patients we're talking about here. The patients with severe TR have worse ejection fractions, more RV dysfunction. If we look at populations with heart failure, we see that having heart failure and having TR has a negative impact on mortality. And also, if we look at patients with LV dysfunction, having coexistent TR has a negative impact on mortality. This is a study from Topilsky looking again at the Mayo Clinic group and trying to understand the prognosis based on the cause of TR. And once again, you see in the middle the patients who have valvular disease, so left-sided valvular disease, or have left ventricular dysfunction, have the worst prognosis. So are the patients who will do the worst if they have TR. Well, is that important talking in a session about mitral? Well, I think yes. I think we look at patients who are undergoing mitral valve surgery, and we look at the prevalence of severe TR in these patients. It can vary from 38% up to 60%. If we look at patients undergoing transcatheter mitral valve repair, such as MitraClip, and we look at two registries, the GRASP registry or the TVT registry, we see again that severe TR, significant TR, moderate or severe TR, is extremely significant and important in patients with mitral regurgitation. Does it have an impact? I think there's sufficient data here too, post-surgery, showing that moderate or severe TR has an impact on the prognosis of patients post-surgery. And there are two studies looking at patients post-transcatheter mitral valve repair, so specifically post-MitraClip. Patients who have moderate or severe TR who undergo MitraClip therapy and don't have the TR treated have a much more severe prognosis. Here, a study on the left, and then again from the TRAMI registry on the right, you see patients with moderate in red and severe TR have a much worse prognosis than patients without TR. So clearly, TR is important, and it impacts patients who are undergoing therapy on their mitral valve. Well, why are we not treating it? I guess there are a number of reasons. If you look at these two studies, these are two studies from the US looking at a similar database and trying to understand what are outcomes for surgery. And they look at a large period, a 10-year period. And we see in the 10-year period that the number of operations are increasing, but not significantly. And the mortality remains high. So in the study on the left, we find a mortality of 8.8%, and patients who undergo replacement or have more comorbidity have a worse prognosis. On the right, you see the numbers of tricuspid valve repair and replacement have not increased significantly over a 10-year period. But more importantly, if you look at the bottom, the blue is tricuspid valve repair and the red is tricuspid valve replacement. We see that over a 10-year period, despite all the advances we've had in medicine, cardiac surgery, the mortality has remained constant, has not changed, sitting at about 8 to 12%. Well, that is really what's pushed and identified this unmet clinical need and pushed the need for having a transcatheter repair device for severe tricuspid regurgitation. The device most used right now is the tricuspid clip. There are well over 600 cases. Most of those cases have been done on an off-label basis. But it's been physicians who've tried to find solutions for their patients who've taken, done the mitral and then used the same device to try and treat the tricuspid. But there's also been significant benchtop data to show, that we can go from bench to bedside to try and teach us how we can address tricuspid regurgitation, functional tricuspid regurgitation with the clip. And what we've learned is that the clip can work, and there's a specific technique. That probably the best technique is to try and place clips on the anteroseptal and posteroseptal commissures, addressing those two commissures, very rarely treating the anterior-posterior leaflets, as clipping them can result in distortion, and we only really treat those in patients who may have degenerative TR. If we look at the real-world experience, I said there was over 600 cases. There have now been numerous studies performed and published, looking where different centers have reported their own real-world experience. And remember, these are self-reported, these are not core lab data, but they do give us a sense of how successful this therapy is being in a very advanced and complex group of patients. If I were to just summarize it for you very briefly, these are the 4 most important studies that we have published on real-world data. They're retrospective analyses, but they give us some sense of the patients being treated. So you'll see the age of these patients around about 76 to 78 years of age. Their surgical risk is high, STS scores about 4%. It's interesting that a lot of patients, depending on the study and the group, have also gotten concomitant treatment of their mitral valves. So they've had a clip on the mitral and then a clip on their tricuspid valve. What's interesting is the procedural success has been pretty high, considering this has been a new therapy, and this has been the device, the mitral device. So it's not been a device specifically designed for the tricuspid anatomy or the tricuspid valve. The procedural success has been pretty good. And you see that it's been effective. There's a reduction in EROA. You see patients who are extremely symptomatic, so over 90% NYHA3 or 4. And despite we're not getting rid of TR, patients feel significantly better. So only a third of patients are in NYHA3 or 4 afterwards, and patients have a better exercise tolerance. But that is self-reported data. So we do now have a study, TRIILUMINATE, it's a CMARC study that's enrolling 85 patients in 25 centers in Europe and the US. It's a single-arm, multi-center study, core lab, adjudication of all the echoes, and an independent events committee. Patients were very well screened. All patients had to be agreed on by a committee, selection committee of physicians, including the core lab, who agreed that every patient was enrollable in the study. So we really did choose patients who we thought at the time are good for this therapy. The device we used was a device specifically designed for the tricuspid valve. So it was not the XT clip, it's the NT clip, but with a different delivery system. A delivery system designed to facilitate the procedure on the tricuspid, to give you better angulation, to give you better height management, and to have a reduced distal length to allow you to manage height and arrive to the tricuspid leaflets in a coaxial fashion. These are the clinical data that were presented for the first time earlier today, and these are just the first 30 patients, and it's 30-day data. The study is almost completed, should be completed by the end of this month with all 85 patients enrolled, and so there'll be more data in the future. But let's look at the first 30 patients. So these were all patients with really severe TR, females in more than half, prior heart valve intervention in almost half of patients. 13% of patients had a lead across their tricuspid valve. Well, that's interesting too. And the Euro score was 5.3. If you look at the clip strategy, you'll see that only a third of patients had one clip, so 2/3 of patients so far in these 30 patients have had 2 clips or more. The average 1.9, and if you look where these clips were implanted, most of them on the anteroceptal leaflets, then the posterior septal leaflets, very few on the anterior posterior leaflets. The acute device success was extremely high, 100%, and the device time was acceptable for a new procedure. If we look at the clinical outcomes, this is a very safe procedure. There were no, up to 30 days, in these first 30 patients, so this is not the entire cohort, I'll reiterate that. There were no deaths, no MIs, no stroke, no patients with renal failure. If we look at other safety endpoints, there were 2 patients with major bleeding, and there were 2 patients with single leaflet device attachment. If we look at the clinical effectiveness, the NYHA improved. You see the functional class NYHA 3 or 4 was in 76% of patients before the procedure. It was in 20% of patients who were only in NYHA 3 or 4. So 80% were in NYHA 1 or 2. If we look at the Kansas City questionnaire, again, an improvement, as well as other quality of life measures. If we look at the echocardiographic measures, again, from the core, these are all core lab adjudicated, really looking at vena contracta, Pisa radius, looking at the diameter reduction as well, and we see that there's a reduction in vena contracta, a reduction in Pisa radius. Patients also had a reduction in tricuspid annular diameter. There was a small increase in gradient, but really not significant, and probably the reason patients feel better is that there's an increase in stroke volume. Very briefly, this is an example of a case we treated in Milano in our center with severe TR, and I just really will show you, for the sake of time, the final result after 2 clips, one of the anteroceptal and one of the posterior septal leaflets. We did see excellent results at the end of the procedure in the study. So it brings me back to the question I was posed with at the beginning: will TRIILUMINATE shed light on MR treatment, considering that almost half of those patients also had left-sided intervention in the past? I think the only data we have so far that helps us is from the group at Leipzig and Philip Lutz, in which they compared patients who were treated on the mitral and tricuspid versus patients treated on the mitral alone. And what they saw in the patients treated on both valves who had TR of both, they really did see an increase in aortic forward flow, an increase in cardiac output, lower BNPs at follow-up in these patients, and also much more improvement in clinical symptoms, whether it was 6-minute walk or NYHA. So I'll conclude. Hopefully I've highlighted that TR is frequent, is often undiagnosed, and majority of patients are not offered mechanical correction of their tricuspid regurgitation. It's associated with the worst prognosis, particularly if you have heart failure, left-sided heart disease. I've also showed you some data that TR and MR often coexist, and that the TR negatively impacts outcome after treatment of mitral regurgitation. There's increasing worldwide experience with the TriClip, and I think the preliminary data we've seen from the TRIILUMINATE study confirms safety and efficacy of this therapy. Could this good treatment in the future of tricuspid regurgitation, either concomitant or staged, improve the outcomes of the treatment of FMR? I think that remains to be understood, but potentially yes. Thank you for your attention.
So thank you, Azim. Now let's go to the discussion again, open to the public. Please be interactive in this kind of discussions, because these are the 2 persons that can answer, 3 persons who can answer important questions. So I want to ask Frank to go a little bit beyond the comparison between the two therapies. I mean, let's move one step forward. I don't think that to crack the code of indication, we should not treat mechanical therapies as antagonists or alternative to medical therapies. I see potential for synergy. So we improve the mechanical function of this heart. We reduce this regurgitant volume. And how can we improve clinical outcomes by what kind of therapy you think would be, what kind of therapy change would be effective to boost the effect of the mechanical therapy?
I think you already said it. The most important thing, the lesson that I take is that from all of this, that we should finally, we've been preaching that for so many years, start working together. Drugs and devices are synergistic. When you look, I made this cardiac resynchronization therapy analogy over and over again. CAT only works in those patients where you, after CAT implantation, by the way, then often the blood pressure goes up a bit, you can then up-titrate the drugs. We've shown that, we've published many papers on that. That's exactly the patients that benefit, that got both. Get that chip out of your head that they are antagonistic, they're synergistic. That's what we have to do in paving the way forward.
Yeah, I think that's a very good point, Frank. And I'd like to ask to Jean-François, when I look at your population, I always try to understand if our expectations are that something would work, we have our clinical observations, why do the results then differ? Do you think that your population, we discussed about that already, do you think that your population is too far end stage, and that if we want to do these therapies, then we need to do it earlier?
Yes, this is the main conclusion we have after our study, but it is also the real life of the clip implantation today. And you have to keep in mind that when we designed the protocol of this study, it was 6 years ago. This is the time we need to draw, to design and to enroll the patient. So it's a long time. And 6 years ago, we thought the clip could be useful in such population, but clearly the answer is if you go if you are too late, it's too late. And this is an important message we receive from Mitra-FR, I think.
That's really important, and I think that goes almost everywhere. When you are too late in the cascade, then reversing it is difficult. So then my question to Frank would be, Frank, how do we better identify patients for a better timing to do this procedure? That's a very difficult question, but what's your view on that?
Well, let's wait 2 weeks. I think once we've seen Coapt, we probably have more data to dive into. The way I look at it at the moment, our clinical practice, Francesco and I, we worked together for many years. The patient on a transplant list is, for me, not a candidate for a MitraClip. It's not. Ship has sailed, and the ship will hit an iceberg. Not going to happen. Earlier on, and that is what I don't know, and let's wait for Coapt, where is the sweet spot? And we have to work on it. The timing is key, obviously after the first decompensation, but not too late, I think, but not too late. And then we have to look at it. Remember, all our devices don't work in all. ICDs, you will know it, in Danish trial, only in the young. Stitch, I consider it an intervention. That's only for the young. The stitches, the long-term follow-up. Atrial fibrillation, Cabana, positive in the young particularly, and overall it was neutral, but in Cabana was positive. So overall, we have to still define where it works. It's not working in everybody.
That's absolutely right, and you highlight various diseases where you see this phenomenon. Waiting too long does not make it easier. So then my question to Azim would be, what about the tricuspid? Because all these patients that we see in this category, you showed that 8% were the ones that was actually what I think have a pretty good chance to repair with a good success. Do you think that the same would hold true for if we would do a trial, a large trial in tricuspid, let's say clipping, that we would have to go earlier as well? And would we have to combine then, because most of them have mitral regurgitation and then also secondary tricuspid regurgitation, do you see something like in combined therapy and at an earlier stage?
Jeroen, that's a great question. And it's something those of us who are involved in the field are thinking about a lot. You know, trying to design a pivotal study, because in the end, we can't convince Frank unless we can show him a pivotal study and a randomized study, okay, of one of these therapies against what's standard therapy. And we've thought a lot about that. I mean, there are two choices. You could either randomize against medical therapy, and the risk then is you would be enrolling a very advanced group of patients, because often the patients who are referred to us for therapy are patients who are failing medical therapy. They're failing diuretics, and they may be way too advanced. You know, there have been suggestions by certain thought leaders that maybe we should be randomizing against surgery. That they may be more appropriate, considering that surgical mortality in recent series still remain 8–9%, that maybe that's actually a fair comparison. I think for now, there is a TRIILUMINATE pivotal study planned in the US, which will give us this data, and for now, the randomization is probably is going to be against medical therapy, but I think we're going to be having the same discussions in a few years, depending on the data, that maybe we intervening too late again.
So before I give the word to Francesco to finalize the session, I think one thing that I've been thinking about for years, and you just brought it up again because we published a couple articles on that, we always look at ejection fraction as a measure what this heart is still doing. But if you have patients with severe mitral regurgitation, half of that ejection fraction goes in the left atrium, and I've said it many times, that the ejection fraction in those patients is not a good marker of how good or how bad that heart is. If you have an EF with severe MR and your ejection fraction is about 25%, the patient with the same heart without mitral regurgitation would have an ejection fraction maybe 12%. So the muscle is far, far, far damaged, and half of that ejection fraction goes in the atrium. So that is an important thing, that we should not stare too blind on ejection fraction, specifically in this sort of trials. So then I give the word to Francesco to evaluate and give us the key learnings.
So I hope that you enjoyed this session the way I enjoyed. I have to say I learned a lot. Not from my presentation, obviously, otherwise I would be crazy. But so I just gave you an initial overview on the landscape, and I wanted really to share with you some of the stories behind this long journey. But then we went into some technicalities, which I think are very important for our audience, for us, share experience. We learned tips and tricks and the new opportunities, the new technical opportunities which are available with the new generation device and what will come later. We have been learning details about these trials, which are changing the landscape of treating patients with heart failure who have also functional mitral regurgitation. I think we have seen two presentations which are the top level possible. You know, I've been at ESC, I've heard your first presentation. I can see already, Jean-François, the amount of thinking and the feedbacks that have been given these days. Already we are going more in the detail of in the depth of the discussion, and obviously I have seen also Frank giving another perspective, which is, in my opinion, very important, that shows how important for us from now on is to focus on finding the right targets for our therapy. So finding the right patient, the right timing. We need to work a lot on this field, and there is a lot of opportunities of working together. And finally, we've been looking at the other valve, which is focus of our interest. It's very early stage, I have to say. You know, this trial, TRIILUMINATE, is a little bit like the Everest, so to say, because we really almost still learning. I mean, we've been learning at least till yesterday. I think most of us, we know what to do now, but it's been a difficult task to apply MitraClip on the right side in terms of imaging, in terms of guidance, and etc. So there is still a lot to do. And besides that, I think it's a fantastic field for innovation, but also for science to crack the code of the right ventricle. Even if the functional MR is difficult, you know, the right ventricle is far more difficult. So having said that, I think it was overall a great session. I thank you very much, everybody, for the high quality of the presentation, including my presentation, which was fantastic. And I tell you, have fun for the rest of the day. I wish you a successful London Valse.